Welcome to Clinical Unfiltered with Dr. Sausha. So give me your hearts, your minds, your teeth, and let's get unfiltered with Dr. Polly, Polly. She's back again with another post. We're going to be looking specifically at SRPs versus periodontal therapy. There was a really good article that kind of summarized like the benefits of it. And I feel like why I want to talk about this topic. I've scuba dived underneath gum tissue enough where I want to tell you guys what I've seen down in there. But also, I feel like the distinction of the two procedures and like why the heck do we go from one to the other? Like why does the flap surgery exist and need to be entertained? Because I don't think it gets entertained enough in clinical practice. So this article, which I think you highlighted in one of your Instagram posts, I think is one of like the foundational articles that explains the differences between the two procedures. So I'm gonna let you take it there, Dr. Polly. I'm gonna share the screen now. I'm gonna share that post too.
Yeah, I just remember being tested on this no matter where I go, whichever exam I take, because this is just so like classic.
Oh, everyone's taking a TQ on this one. They just maybe don't know why they took the TQ. You know?
Yeah. So I mean, it's a study done in 1986.
1986. I wasn't alive yet, for the record.
Oh my gosh, am I older than you? I'm older than you. I am alive.
You're older than me.
I'm alive. I was 1 year old. Yeah.
There you go.
Wow.
There you go. Confessi. Polly, you were born. You and the inception of this article are linked together. SRP versus flap surgery.
Yeah, I was 1 year old. Yes. Do you remember who they got this study? Like who did it? Because you know how sometimes it's like they have the dentist and then they have the hygienist.
Gotcha. Confessi, RG. No, I do not. But you know who does know?
ChatGPT.
ChatGPT. ChatGPT.
Imagine if we had this resource when we were in residence.
Absolutely. Okay, so we're going to ask ChatGPT.
Yes. Because I just want to know more about it. Because I remember the bottom lines, right? Because that's what we get tested on all the time.
Author, and are they a dentist? And what other question would be a good one? Where did they do the study? I do like to know that often. Honestly, it would help paint a picture when I would read these articles, and I would try to get an air of like, what was the setting? The scene.
Yeah, exactly. It was done in like the university. Was it done in private practice?
What they need. Like a Netflix documentary for all these things, like little shorts, like an anthology for all these episodes where like that you get to feel like where the environment is and like throw in a sex scandal or something in there just to like make it spicy. Like, oh my God, I can't believe Confessis and it'd be an easy one with Cairo and Miller. We could easily set up.
I want to. So you want to know about Confessi? I want to know like who did the SRP and who did the flap. You know what I mean? That's what I want to know. I don't mind knowing about Confessi. I mean, we just know their names, but we don't know about them.
Oh no, Confessi. Okay, he was a specialist, and this is a Michigan. Is this one of those Michigan studies? Did surgery later in a master's in periodontal in Michigan.
Oh, I remember.
Where the study was conducted in Michigan. Yes. Okay.
University.
And so like as far as like how are they actually like who's doing the SRP? Did they do the flaps?
Yeah.
Because they would have separated the two. They would have done SRPs separate from doing the flap surgery. Yeah. You wouldn't get both. You didn't do SRP and then follow it up with a flap.
Yeah.
Or did they? Because, I mean, how would they know how much they got off the surfaces of the teeth? They would have had to figure out how they got the calculus off the teeth after an SRP.
Yeah.
They would have had to figure that out.
Yeah.
Yeah.
Was it like a split mouth design where like a patient comes in?
How was the study done?
Yeah, exactly.
Here's a clean, yeah. It is done. Control split mouth design. Yeah. Different treatments were performed in different quadrants of the same patient. Okay.
Who did it? The dentist? I guess the residents maybe, or the periodontist?
Yeah, if it was in a university setting, it would have been like probably periodontists and residents together.
Was there a lot of How many people are in this study?
21 patients were included in this study. 2 teeth were treated with scaling only. 2 teeth were treated with scaling after flap elevation. 2 teeth were left as untreated controls. Wow, this is phenomenal. Can you imagine? Yeah, you're right. If we had this ability to break down our articles, just kind of upload the PDF and just like ask it the questions
Yeah, it's
that you wanted to know.
so
Yeah.
nice. Because we just need to like, I think if we want to talk about it, we need to know all this.
The SRP versus flap phenomenon is, I think, where this this is where I want to go with this. Is so, I mean, from an SRP standpoint, I will tell you, I do feel like when I've watched the GP setting go, like when they're trying to treatment plan patients, I feel like a lot of, like probably 5 to 6 millimeter pockets don't get pressed into an SRP roll. And being someone who's been underneath the gum tissue that much, I know how much, calculus is underneath the flaps, as underneath the gum tissue. And I feel like, if you like, that's the one thing I like about this study is that you're seeing these numbers of what calculus, like how much calculus gets left behind essentially by showing you the opposite, like percentage of tooth surface completely free of calculus after USRP versus how you flap. And when you're looking here, it's like the greater than 6 millimeters, the amount of tooth surface that's completely free of calculus is 32%. That means how much of it still got calculus? you know, a lot of it. A lot of it has calculus still. And these 5 to 6 millimeter pockets, like, I don't think a lot of people, or even here, there's 4 to 6 is half of it's still got calculus, 43%. I don't think we respect that notion enough. I don't think there's enough of like, okay, when they're having this kind of pocketing and inflammation, we're going to be able to remove. There's a lot of confidence in how much we can remove. And I don't think that actually plays out.
For sure. Like, I mean, well, I was a hygienist before. All I did was like SRP, right? And then like, I think we just like we're taught that these are great instruments. They're gonna go long, they're gonna go deep. And even if I bring this up sometimes, like I would have, and I don't mind them challenging me, I would have hygienists that are like, well, the study was done, so long ago. And they were told that now in like 2026, there's like these extended minis that may not be available when the study was done. How do you feel about that?
Because you wouldn't be able to get calculus off
They
from
were,
like
yeah, it's,
type.
mm-hmm.
Yeah, I didn't even realize they had like advanced the hygiene instruments to that point where they are like, okay, you can't get this spot, because there's certain spots where like even when I'm flapped open, like I will run a burr over a piece of calculus in a specific area and I'll look at it and I'm like, dude, that calculus is still there. And so they created curettes for that. I mean, that's great.
Little curettes. It's called micro mini blade curette after 5 curette, and then it just goes further, further, further down, and then the tip just get thinner, thinner, thinner. So the challenge is, well, this study was done in this time, and these mini curettes with extensions may not have existed. So now, see, that's what they're saying now that all these companies are telling us that with these, mini extending curettes, like we can reach further. How do you respond, or how do you feel about
I
this?
got you. Yeah. I see what you're saying. So now you're saying it's skewed. Like now we can get calculus better through an SRP because we have better instrumentation for it.
Yeah, that's
Yeah,
what
that's got to be
they're
true.
saying. See? So this
Gotcha.
that's the
Yeah,
factor 5, that's the mini. Yeah.
that's got to be true. I see what so
So
that's
it's
got to
like,
be true.
oh, okay.
That's got to be true. But again, another point to this Cafessi study in 1986, they did also show when you flapped, you're still leaving stuff on there. So like even when you get visual access and honestly can start using more instruments, you're still
Leaving quite
leaving
a
a ton.
bit.
Yeah.
Yeah.
So you can get all the fancy instruments until you actually blow out the surface of the
Yeah.
tooth.
Yeah.
You're not going to get this stuff off. So I will admit it's got to be better. The numbers have to be better with better instrumentation. But with that said, still in an SRP format, I do think You're not even if the thing is, I think the problem starts initially when we're not even doing SRPs. Like we have a problem within our office group sometimes in getting the therapy to move on to an SRP when we know there's like inflammation and 5 millimeter pocketing. Like at least do a freaking SRP. Like I mean, even though the studies are showing it's not going to get full improvement. I mean, God, imagine not doing that. Like do that. Don't not do that. That's like pretty straightforward. I mean, that this study, as old as 1986, simple, went in there to show you that you are not getting the stuff off in those mid-range pockets. And to even forego that is insane. But I mean, even again, the flap part, you've done it. You've thing is it's unique. I guess you've been a hygienist to do it without flapping and then got to experience then flapping, which I bet makes you better at getting it off when it's flat.
I think we can all say that when we see things, we're more likely to be able to get it. It's just like tactile sensitivity, right? If you're not, the pockets are deep, you're feeling it. Yes, even if the instruments reach that deep, how often it is that, if you're burnishing it, that it would still feel smooth, but it's actually stuck on there. Like, and not to say that they even burnish it themselves, but what if it's burnished by another person, right? And then now it's like, okay, now you're feeling it and it just like feels smooth. That's tactile. So then with the flap,
Take our word for it.
yeah.
Smooth calculus is burnished calculus is smooth. It is so smooth.
And those are
It is smoother than Matt's bald head. It is so smooth.
It's so true. And then when you flap it and then you see it right there and you're like going at it with like the highest power cavity, guess what? Sometimes it doesn't come all the way off, right?
Well,
Like
it
it's just
stares
like
right
it's just
back at
there,
you.
right?
Like a
Even
little
when
calculus middle finger just staring right at you. Like, yeah.
so even when we
Yeah.
can see it, it doesn't even mean that it's easy to take off. It's just that at least we can see it. So I think it's that visual
Well, I mean,
that
that
helps.
in your post right here, I mean, it's even like, I mean, saying flapping
Always at
works.
the CJ. It's always at the CJ. And
It's at the
then,
CJ. So I mean,
yeah.
even flapped here, you can look like percentage of tooth surface completely free of calculus. Greater than 6 millimeters is probably, which is interesting because that's probably when you're gonna flap most of the time. Even that, with it flapped, you're at 50% of it still having calculus, still having potential calculus. Not to say it's 50% covered in calculus, just surfaces is what it's saying is the surfaces, there might be a speck of calculus on it. And that number right there to me means, and you kind of described it in the bottom line of the bottom line here, where it's like there is residual calculus even when you have potential visual access. Because, I mean, you've been in there. I mean, what sometimes even though visual flapping does not always mean visual access, you know?
Yeah, you're like all the blood's in your way, all the saliva, all the suction, and then
You don't use lasers, do you?
me.
You haven't worked with lasers?
You know what? When I was a hygienist, my boss sent me to a dial laser course, and I even got like a certification on that. But that just to like disinfect the pockets back, way back, right?
Gotcha.
Like 20 years ago when it first started.
Okay, interesting. Gotcha. But you didn't use it to to actually trim or
No,
cut
no,
tissue
no.
with the
How's
diet.
your?
But you were allowed. Yeah, you were allowed to use it with that. I do. I have the Perio lays. I have the Millennium Lanap laser. Um, and I probably use it a little bit. I do like a modified version of the
Mhm,
Lanap where I will try to get more visual access.
mhm.
Because it bugs me knowing if I leave a piece there, and I know the tactile sensitivity. I've
Yeah,
been underneath the gum tissue enough
right,
to know that tactile sensitivity is
right.
not enough
Yeah.
to know if you got everything off those root surfaces.
Mhm.
It's tricky. It's tricky to get these root surfaces clean, even when you have flap access. And I think that's critical. It's like if you've never seen what calculus looks like under a flap, like go hang out with your periodontist or like go look at those photos. And I feel like you will then see that calculus is tenacious underneath the gum tissue. And then an SRP needs to be more, again, it all boils down to like at least do the damn SRP and then consider further therapy is because again, these studies show that like the SRP might not be sufficient enough to get everything off. So you need to consider further therapy, whether that's a laser to get more visual access and kill or flapping it open. Now osseous, I mean the flapping procedure in the version of osseous. Um, what's your like typical go-to when you're doing that? And are you doing in that sequence SRP and then what's still lingering, then moving on to osseous?
It depends. Like if I think with the experience, we're gonna be like, okay, looking at this person has always seen the hygienist like every 3 months, and it still looks like, eh. And then it's like, do we really need to do that SRP first before doing that? At that point, it's like, you know what? We've been doing this for so many years. You've been on this 3 month recall, and let's just jump straight into flap. There are cases like that. But then there are cases where I'm like, no, 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 like the tissues are so red, they're bleeding, they're blah, blah, blah. Let's just do phase one first. It really, really, really depends.
Gotcha. Okay, that's an interesting thought point. So like when it is like you've obviously been keeping it clean, so whatever's left in there has got to be the tenacious stuff.
Yeah, they've been on maintenance forever, and my hygienist, who's really, really great at what she does, and she numbed the patients up already, during the thing to do her SRP, and she's like, dude, I can't get this off. I use all my mini meat, I use the extender, I turn it on high power, and it's still like this, right? I'm like, okay, well, I give the patient a choice. I'm like, I don't know if I'll do a better job than the hygienist, but like if you want to do phase one therapy, let's go for it and then see if you respond to that. Or I don't think it's wrong to give them the option to jump straight into it.
Well, I mean, the thing is, the only thing in that thought process is they've probably been through a phase one therapy at some point. If they've been going through 3 month cleanings, yeah, so they probably still had it, just God knows when they had it.
Yeah, or they just forever stayed at phase one therapy if you think about it.
Yeah, never moved on to the phase two of getting the osseous. Now I will tell you my thought process when it comes to like, okay, we're gonna push this patient to an osseous therapy. Um, since I've started using the laser, my general focus has actually been like preservation, and I kind of believe in that. Like I don't remove as much bone as I used to. Mainly because like in the end I've realized it always boils down to like them like I can get the calculus off. If they decide not to keep the calculus off and keep it off, I could remove all the bone in the world, it's still coming back. I could remove the little bone, like
Yeah, 1,000%. Because I'm on the same boat. So when I say osseous, I'm not talking about like classic osseous. I don't do that because we open up the flap. You're gonna see some negative architecture. You're gonna definitely see some areas where you can fill that you can regenerate. You're gonna see some that you can't. It's not gonna be like, oh, this is a regeneration case. Oh, this is an osseous case. And then remember those studies that say that like if you do osseous on people who can't like maintain their oral hygiene, it's actually gonna be worse. Yeah. So I keep that into consideration. So I keep a lot of the tissues. I don't do the classic like what you were saying, like you don't take out as much tissue, as much bone. Yeah, same thing. It's basically very tailored to that patient's everything. I look at the phenotype, even of the gums and then the kg and everything, all that considered. So I'm regenerating a lot more. And I see the results like preserve. Like even if
the
I don't
pillow
regenerate,
preservation
I'm
technique.
like
Is that what you're kind of
I'm preserving.
referring to?
Well, a lot of times if they don't have KG, I'm not gonna do my like, the
Okay, gotcha.
thermometer thing, But I
Yeah,
try
they
to,
need a fat papilla to do
yeah.
papilla
When I
preservation.
do
Yeah, yeah.
my flap surgery, right, I'm gonna regenerate some areas, and then some areas I'm gonna flatten because it makes sense for the flap to go on. But I try to, tissue-wise, I do try to preserve. Like it's very tailored. I just think, okay, this tooth, that tooth. I'm sure it's like, it sounds like we're on the same boat with that.
Yeah, no, I like if it's a thin tissue biotype, the less I mobilize, the better. Honestly, the thin tissue biotypes are I actually really like the laser on the thin tissue biotypes because it doesn't take much energy to get access. And I don't end up flat, and I pretty much don't even touch facial tissue. Like it doesn't even get touched. It's mostly interproximal, where honestly, most of the time the calculus is if they're a thin biotype patient and they've got calculus, they're going to recede. If they're a thick biotype patient, their gums are thick, then that's when you develop those weird pockets and you need more access.
Actually, me and George talked about this. I think when we graduated, he was like, "Hey, are you like doing all those like osseous?" And then we talked about it. We're like, "Hey, but isn't there studies like every time you flap, you're gonna probably have some recession anyway. So why are you taking off more? It's gonna kind of the body's gonna do it itself, especially when it's thin." So it's like, yeah, we do all these studies and then we learn all these procedures, but when you practice, I think we all have the same mindset of
I think this is my analogy is the traditional osseous to me is like extension for prevention, where it's like yes, we used to do silver fillings, and yeah, they kind of worked. Um, but there is kind of maybe a better way to do it and a better understanding. So I consider it a little bit more old school. And I do notice that some more old school periodontists were like still love osseous, still poo-poo the laser for all its attempts to be different. Um, and but I do consider it that. Like it's an extension for prevention. That's what they're doing. They're like, oh, we're gonna lop off all this bone so that gum tissue can't grow back and you can't get food stuck in there. And the patients are like, guess what? I'm going to still not do floss. So you go to hell, osseous. I'm going to still develop gum disease. And I've had that happen.
it speeds up. It speeds up,
Mhm.
yeah, unfortunately. And
and,
then, hmm
and I will tell you though, I have noticed with regeneration cases as well, guided tissue
hmm
regeneration, it's the same principle though. It's like if you are doing that and you're going to have a patient who then again does not decide to do their home care, it actually, if anything, you've added an insult to an injury by adding some kind of tissue material. So I'm a little bit more case selective when it comes to guided tissue regeneration. Like I have this open concept where I'm like, I look at the patient and I'm like, all right, like how much do you, like, because you're gonna have to pay more. You're gonna have to pay more, but there is a shot at us growing some of this bone back. When I go in there. But if I do that, if you're paying more and I'm putting this more material in it, it's tougher to heal. You have to take care of it. And if I get a hint that they're not, I'm just more focusing on like debridement, getting bad off. Because I never hate myself for cleaning off calculus. Like that is always a service. That is always a service to the patient, is to remove etiology.
no, I agree. Like the least you can do, right? It's like if you don't want to do this, like let's do that. I feel like the patients that understand and then that say yes to like the more regenerative procedures and they're paying for that service, I think it's the same thing. It's like, my mom paid for my braces when I was young, but now I'm paying for my own braces. So I feel like I'm gonna wear the retainer more because it comes out of my own money. So I do see that like when I show the patients, their vertical defect and in 6 months there's like bone fill, whatever, they're like very motivated. Most of them, I would say, they're very motivated because they see it. They're like, yeah, they're like taking pictures of their thing, and then they notice that hey, it's not mobile. It feels, and then
Tighter. Yeah.
yeah, and they're here. They're like here for every recall, every
It's
hygiene.
funny. The most common thing that I get that patients like is they're like, "Oh, I'm not spitting out blood when I'm brushing." That is the most common. That is my number one like compliment after periodontal therapy is like I'm not spitting blood every day. And I'm like, "Wow." I'm flabbergasted that you were cool with that for a while, like it's no big deal, just blood in my
A
mouth
lot of times I
all the
think that's
time.
just normal or something. Yeah.
But again, I mean, I kind of fault some general dentists out there that are listening that are probably like, oh, yeah, I'm keeping that patient chilling on that bloody papilla, that inflammability. They do that. I've seen it happen left and right, mainly because it's like, I do feel like to get a patient to understand the problem of periodontal disease, to even jump into SRPs is tough. It's tough. It's a hurdle for a lot of dentists. Again, back to like our prior conversation about classification system and communication. Like for me, that's such a big problem in perio is communication that it's like the reinforcement point. And then once you can get over that hurdle, do SRPs, and once you can get over that hurdle, understand if you need further therapy because again as the research shows in that post all those things are probably needed to get the patient to a healthy state, and by holding back or trying to take it easy on the patient you're just harming them
You're forever
because you're
in
scared
phase
of them.
one. You're forever in phase one, right? And you're not seeing
Yeah.
improvement. But I do think that, like, in terms of like their dental IQ, I do think hygienists play such a big role.
Oh,
Like, geez, they come to me and they want it, before I even tell them anything, they're like, I have this problem, I need it, fixed. Even if it's not predictable, whatever, like, what can you do to help me? And I feel like a lot of my referrals are from like hygienists because they do the recalls. They know they pick up on the things, right? Yeah, and then the doctors are more in and out for cavities, and I don't blame them. That's what, they're focused on that because they have the hygienist to really focus on the perio part.
and that from a standpoint of like a general dentistry office, um, if and most offices I think do this, they have a hygiene like the patients run through hygiene. That's very common here before they even see the doctor. Um, And if that is the initial point of contact, that you really need to make sure that the hygienist has their lingo down, like their script down to impress upon the patient. They need to sell the SRP. They need to sell that SRP to the patient. You just need to reinforce it.
They have the time spent with the patient right there in front of them. They have the time to really educate them and build that rapport with them that, a lot of the times when the referrals come from those hygienists, my work is done. Like they come in, they want treatment.
There are courses. I have heard of courses where they'll train like it's geared towards this problem alone is SRB
I did that
conversions.
presentation on just
There you go. Yeah.
specifically
Yeah.
for hygienists, and then it just like the referral rate just like, because a lot of times, like even when I was in hygiene, I wasn't told that there is something like phase two therapy.
Hmm.
I was just told to just keep scaling, right? Like to just keep
Right.
scraping at these. And I wasn't told that there's this other thing. So just because I didn't know about it, that's why I wasn't doing the referrals because I thought, well, this is all they get, right? And you'd be surprised when I talk to, these hygienist groups, like they've heard of osseous, but nobody ever really explained to them like what these are osseous regeneration or like these phase two, like what we have.
Oh God, yeah, especially just regeneration. I'm just like starting at like just getting the calculus off another way than SRP, and I can imagine a lot of them are missing even regeneration as a concept.
Or they sent them before to osseous and then the patient come back with all these like bigger embrasures, more food getting stuck, more food impaction, and they go down and then they're like, well, why should we refer, right? But then once you educate them on, hey, with technology or like perio, we're moving forward to like more like preserve,
Preserve, right?
yeah,
Yeah.
regenerate. There's like all these biologics out there that probably wasn't available back then, right? That they have all these growth factors. We're doing more like, PRF, like, these bioexclude membranes, like all these things available to us.
And I feel like for hygienists to know the spectrum of treatment is critical because then they honestly, I feel like if a hygienist doesn't and they feel like SRP is like the last stop, they won't push SRP on a patient because they'll try everything else before. But if they know that there's a spectrum and SRP is like step one, it's much easier for a hygienist to step in and be like, okay, let's move to step one. Let's at least start at step one. And I don't know if you can tell, Polly, this is a problem that like we've run into within our offices that we've noticed. So it's not just us. I've noticed it's a consistent problem amongst most. And again, you were a hygienist, so you
I
remember
wasn't
that side of
exposed
things,
to that.
right?
My main
Or is it-
thing is like, in dental school, I was taught how to do SRP in like 2 hours, right? But in hygiene,
Yeah.
that was crazy. It was like 2, 3 years I was taught how to do SRP. We're focused on that, because it's not our scope of practice to do phase two therapy. We don't know much about it.
Right. But it is the scope of practice and it just by chance that it is the hygienist's job to get them to push them out the door into the world of perio therapy.
No, we wouldn't know of the patient sitting there because we're not the first person of contact. So when I go to GP offices and do my travel perio, I tell them, hey, I have this presentation and let me talk to your hygienist. And that really did help.
Oh, interesting. Okay, so I got to do more of that, but it'd be I feel like that it should almost be like a standard. Like if you're a GP office, let's say you don't even have a perio referral because you feel like you could do flap therapy, everything in house, either sit down to your hygienist or find your local periodontist, have them. Have them just give the talk. Get
Yeah,
throw them a bone.
yeah.
Be like, yeah, we'll refer one day, and then just have them talk to your
No,
hygienist and
yeah,
have
if
them learn
GP
about
does
it.
their own flap, like that's a great way to just, they just need to know there's something further.
Yeah. And I'll tell you, part of me was like, okay, maybe we get into the nitty gritty of how we actually do osseous, but I actually think it's more important that we just figure out how to get to that point. And I thought that was a good step we took at this episode. We will come back at another point and talk about techniques, which include regeneration, because I saw you had a post on like papilla preservation. There are many different ways to actually accomplish this less invasive format of going in and going. So flap, the word flap in this study is a little bit more old school. Nowadays, it's very expansive. There's more than one technique to be able to approach cleaning this calculus and saving tissue. Polly, thank you again for joining me on Clinical Unfiltered. Till next time, guys, follow, link. No, I'm just throwing out like random tech words now. Follow, comment, like, give us suggestions. Go follow Polly. See her posts. They're great and they really really educational and pretty easy to just flip through. uh, Take care, guys.